So in our cutoffs, as we're establishing, we have true positives, true negatives, false positives, and false negatives. A true positive is a sick patient who gets a positive test. So whatever cutoff we've used or whatever the test that we've used to identify the sickness, it has accurately diagnosed that, yes, we indeed have a sick person. That would be a true positive. A true negative is when we have a diagnosis or a diagnostic criteria, a method, a test that has successfully identified our healthy patient. So the patient tested negative for the disease, they were within the reference interval. I run the test, and sure enough, they are a healthy person falling within the healthy range. That's a true negative. A false positive is when you have a healthy person who tests positive for the disease. And a false negative is a sick patient who is testing negative. We can imagine creating a table like this. And this will be tonight's homework, the homework due tomorrow night, or tomorrow afternoon before the quiz. And we'll have maybe one or two questions on the quiz that are related to this, establishing a table like this. So you have your patients that are testing positive, both your true positives and your false positives, and you have your patients testing negative, your false negatives and your true negatives. Likewise, you have your sick patients, and some of them are testing positive and some of them are testing negative, and you have your healthy patients. Some are testing positive and some are testing negative. Ideally, we want all of our results to fall in either this category, true positives, or this category, true negatives. We don't want any false positives and we don't want any false negatives, because those are the inaccurate results, right? We want all of our results to be true and accurate, but realistically, we're never going to get that. We're always going to get some amount of false positives and some amount of false negatives. 6 terms to know. Sensitivity. Sensitivity is the percent of sick patients who test positive. We calculate it by taking the true positives, dividing by the total number of sick people, and converting that into a percent. Number of true positives divided by the total number of sick people, which is going to be the sum of our true positives and false negatives, right? We're in agreement. These are all our sick people right there. And then we convert that into a percent. The specificity is the percent of well people who test negative. That would be our true negatives divided by our total number of healthy people. Total number of healthy people would be our true negatives plus our false positives. And we convert that into a percent. So one of the first things that you're going to be concerned with when you are bringing on a new method or new assay, or you are starting to do some new testing, is the sensitivity and specificity of that particular test. Sensitivity and specificity. And there will be industry standards and regulatory requirements as to what the minimum sensitivity and the minimum specificity are for a particular test. And that may sometimes be a subject for debate. Right now, that's a huge area of back and forth for COVID testing. What is the minimum sensitivity you need for a COVID test? What's the minimum specificity you need for a COVID antibody test, right? If a test is so sensitive that it misses the disease half the time, is it worthwhile? And so we'll get into some of that next. Positive predictive value is the probability that a positive test result predicts that a patient has the disease. Probability that a positive test result predicts that the patient has the disease. So it's your number of true positives divided by your total number of positives. And you convert that into a percent. Now make sure that you are distinguishing between sensitivity and positive predictive value. Typically on the exam, these are the things that folks mess up. They mess up the difference between sensitivity and specificity and positive predictive value and negative predictive value. Negative predictive value is the probability that a negative test result predicts that the patient does not have the disease. And that's your true negative divided by your total number of negatives. So your lab may be more concerned with these numbers, with the sensitivity and specificity of your tests. From the doctor's end, from the medical care end, they may be a little bit more concerned with the predictive value of the results. And we'll see that sometimes the predictive value does not always correlate well with the test accuracy itself. Sometimes it can be very deceptive. Efficiency of the test, or perhaps the accuracy of the test, total number of accurate results out of your total tests run. Accuracy of a test, efficiency of a test. Prevalence of the disease, total number of sick people out of your total population. As of late, positivity rate has also been of an interest, statistics of interest, right? How many of your test results are coming back positive? All right, so let's give this a shot here. We have 250 volunteers that are selected for a new test method. And we've got our new method, and we've got some type of gold standard confirmatory test to determine whether or not they are truly accurate, truly sick or truly healthy. And so say we are doing this test and 18 people are truly sick and everyone else is healthy. 2 people of the healthies, 2 healthy people test positive. And 5 of the sick people are testing negative. Those are 5 false negatives. So let's create our table. So this is what we start off with, yeah? 250 total, 18 are sick, 5 false negatives, 2 false positives. What are my other numbers here? How many true positives do I have? How many true negatives do I have? So if I have 18 sick people total, 5 are testing negative, how many are left over that are testing positive? 13, right? Because I have 13 plus 5 is my total 18. Now, if I've got 18 sick people, how many healthy people do I have? 232? And if 2 of those are false positives, that means the remaining 230 are true negatives, yeah? So I have total 15 positives, right? 2 false positives, 13 true positives. And I have 235 negative results. 230 of them are true negatives, and 5 are false negatives. Simple enough, calculating true positives, true negatives. So let's give a positive predictive value a shot. What's the positive predictive value of this test? My positive predictive value is going to be my number of true positives divided by my total number of positives. 86%, 86.7%, 13 divided by 15, yeah? Agreement? Thumbs up? Confirm? Awesome. Negative predictive value, what's that come out to? $97.9, 230 divided by 235. Everyone get the same answer? How about sensitivity and specificity? So my sensitivity is 13 divided by 18. And my specificity is 230 divided by 232. What do we got? So 13 over 18, and we get 72.2%. Yep. And specificity, 99.1%. Yep. Awesome. Very good. So your ideal distribution will look something like this. We have a clear, identifiable cutoff between our healthy and sick population, and our healthy will always get true negatives, and our sick will always get true positives. When this is the reality, we get a reference interval that's drawn somewhere around here, yeah, which will give us a certain number of false negatives. Because we have someone who's actually sick, but they're falling in this range. And then we have some healthy people that are a little outside our reference interval, and those are going to be our false positives. Where we draw the line, this cutoff line here, depends on what we want to get out of the test. Depends on how serious the disease is. How important is it to diagnose it quickly? How treatable is it, right? If you've got a very deadly disease, but it's very treatable, you want to catch it as early as possible. So you want to be very conservative with your cutoff. You want to limit your number of false negatives. So you can use a borderline approach. One is establishing a reference interval here, establishing your cutoff for a clinical decision over here, and then having this gray area over here. Now, the disadvantage of doing something like this, you're not going to get any false negatives and you're not going to get any false positives, but a lot of your results are going to be pretty useless, right? You see that? The end result of something like this is pretty low sensitivity and pretty low specificity. Now let's say you want instead to catch a very serious disease that's very treatable if you catch it early. Then you want to be as conservative as you can with your cutoff value, so you establish a reference interval like so. You don't have any false negatives. You're catching all of your sick people, because that's what you want. You want to catch all your sick people, and you're left as a result with a bunch of false positives. Which is okay, because then you can follow up with a confirmatory test afterwards and determine whether or not those people are actually sick. So the strategy for something like this, if you want a screening test for a very treatable disease and you want to catch it as early as possible and as many people as possible, you want the highest sensitivity. And you're willing to sacrifice specificity to do it. High sensitivity, and you're sacrificing specificity. And usually between these two, there's a trade-off. If you're willing to if you really want high sensitivity for drawing your cutoffs, you're going to lose out on specificity as a result, right? Because we can see the further back I draw my line here to cut off from my reference interval, the more false positives I'm going to have, which means I'm sacrificing specificity to gain sensitivity. Then afterwards, I can have a confirmatory test. So I take all the positive results from my screening test, do a confirmatory test, and that one is going to have higher specificity. And as a result, I'm able to get rid of all of my healthy patients that tested positive, and I'm left then with my true positives. So this is a method that you can use. If, say, you have a very expensive confirmatory test, but a very cheap screening test, right? I can't do my confirmatory test on everyone because it's too expensive, but I can use my screening test to rule out 60, 70, 80% of the population that come in for the test. I can rule those out and then just do my more expensive test on the 20% or 30% that tested positive for my first one, right? So if my confirmatory test costs 10 times higher than my screening test, by doing a screening test first, followed by a confirmatory test, even though I've done two tests, right? So you would think, oh, that's more expensive. You tested everyone, and then you tested some of the people twice, so that's two tests, it's more expensive. It can end up being cheaper than if you tested everyone with the expensive one. In general, highest sensitivity is desired when the disease is serious, should not be missed, and the disease is treatable. You want to catch it as early as possible, start treatment as early as possible. Highest specificity is usually desired when the disease is serious but not particularly treatable or curable. And knowing the disease is absent has a public health value or psychological value. So you'd rather not have any false positives because all it does is stress people out and there's not much you can do about it anyway. Highest sensitivity is when there's a lot you can do about it and you want to catch it quickly. Now, there's a few other categories that can pop up here, and we'll take a look at them. Let's say you've got an antibody test. This has been a big talk with COVID, right? COVID antibody screening. Now, say you've got an antibody test, and it looks pretty good, right? It's got a 98% sensitivity and a 97% specificity. Looks good, right? If I had a test like that, I'd say, all right, this is a fairly accurate test. It's going to give me the correct result most of the time. Now, say I'm doing an antibody survey in the population, and this is COVID, so it's only just started to break out into the population now. So say the population I'm surveying only has a 2% disease prevalence, meaning only 2% of the population has had the disease up to this point, right? It's a rare disease, so we don't expect many people to have antibodies yet. We expect maybe 2% of the population to have antibodies. And I randomly survey 10,000 people, which is what these antibody surveys are doing, right? That's been the goal of these surveys. So I survey 10,000 people, 98% sensitivity, 97% specificity. Let's fill in our table here. 2% disease prevalence. How many sick people am I going to have? How many healthy people am I going to have? $200 sick. Yep, 2% disease prevalence means 200 people sick, right? 2% of 10,000, and leaves the other 9,800 are going to be my healthy individuals that I test. Now, if I've got 98% sensitivity, how many true positives am I going to get? 196? 196 true positives, yeah? And the remaining 4 false negatives. Now, how about my true negatives here? 97% specificity. How many true negatives am I going to get? 9,000 what? 506? Yeah. And the remaining 294 are false positives, yeah? So what is my positive predictive value and negative predictive value for this test? So total positive results I've got, total negative results I've got. 40% positive predictive value and 99.96% negative predictive value. Now, wait a second. I thought this test was really accurate, right? It had a sensitivity and specificity of 98%, 97%. But a positive result is barely a coin toss. It's a 40% chance of a positive result actually being accurate. Because the disease is so rare, 2%, that the lack of specificity, the effect of the lack of specificity is actually greater than the prevalence of the disease itself. So for a really rare disease, losing out on specificity will leave you with mostly false positives. And that's a challenge. And that was a big subject of debate when antibody screening first came out for COVID. Because with a very rare disease, a minor drop in specificity was enough to make your predictive value of your antibody result completely useless. You tell your population, oh, you have antibodies to the disease, and now you're resistant to it, but half the time it's actually a false positive, and they didn't actually have it. And it doesn't help that you didn't have a clear knowledge of who had the disease to begin with, so you don't even know who to properly test for the presence of antibodies or the absence of antibodies, right? So you're testing a bunch of people. You don't know who actually had it. You don't know who had it and who didn't. You don't know who's got, of those that had it, how many of them developed antibodies and how many of them didn't. And so it's very difficult to establish a new protocol, bring in a new test. And so that's why right now up to this point, antibody testing is still mostly being used in the context of population survey and research, rather than an on-demand, you have the antibodies, therefore you are now resistant to the thing. But let's change the math up a little bit. Let's say now the disease has a prevalence of 30%. Do all the same math. Let's do all the same calculations. $3,000 sick, yeah? 7,000 healthy, means we've got 2,940 true positives, 210 false positives. Our positive predictive value, now a nice, great 93.3%. Negative predictive value, 99.1%. So now that the disease is more prevalent in society, more people have had it, now my antibody test actually means something. And this can be an issue for not just COVID, but for other diseases. There are some tests that when it's not flu season or it's a seasonal disease and it's not the right time of the year, the test is completely useless because your number of false positives are going to outweigh your number of true positives. So it's going to be very interesting as we have more COVID outbreaks now around the US. I'm hoping they're going to realize that antibody tests are now going to become more useful. And more, for some reason, they were a big thing in the beginning. Everyone was like, oh, we can get antibody tests and test everyone for an antibody. And then for some reason, that just fell out. I think enough researchers were able to convince them that you can't do this right off the bat because your results are not going to be useful. But I don't think people are realizing that now we're starting to cross into this zone here where enough of the population has had it in some of these big hit cities, right? Los Angeles, New York, Dallas, Houston, all these Phoenix, all these areas that have had big outbreaks now antibody surveys are actually going to mean something. What's interesting is a friend of mine was sharing this a couple days ago. I've got a lot of friends over in Fresno, and there is a small Fresno school, I think it's a private school, that seems to be our first example that we've got that had a major COVID outbreak back in the spring, back in February. So this is a Emmanuel school starting back up now, and they were in a big fight with the Fresno public health folks about restarting classes in the fall because they were trying, the Fresno County Public Health was claiming that it was a danger for the school to be starting back up. And what's interesting is one of the parents of one of the kids there, I don't know him, but Dr. Paul Admadjian, he's a pathologist and hematologist over in Fresno, and he and his whole family had COVID back in February. And they got very ill, and he realized afterwards, and I know this wasn't on anyone's radar in February that you were going to have COVID outbreaks, and he realized afterwards that they probably had it, so he put together an antibody test and gave it to, he's a pathologist, so he gave it to the whole family. His whole family tested positive for antibodies. And so he's like, wait a second, we had a really nasty flu season at school in January and February, a huge rash of illnesses, kids sick, teachers sick. We were thinking it was just the flu, it was just the cold. What if it was not? And so he did a antibody survey for his school, tested a couple hundred people, and 59% of the sample population from the school, 198 people, tested positive for antibodies. And they are using that now to justify we can resume school because if these results are real, this is basically herd immunity. These are results that are similar to what we've seen in like prison populations, where everyone is trapped together and you get a prison outbreak. You reach herd immunity somewhere in the range between 60 and 80% of the population once they've got it. So if this is true, and that's 59% of the sample population compared to other section in Fresno that did not have an outbreak, and they got a 5.5% positivity rate. So this difference, this is clearly due to actual COVID antibodies, right? Maybe you can say that there's a slight inaccuracy in the test, and maybe that's where this number comes from, but 59%. So this would be our first documented case of an actual outbreak in a school setting. Up to this point, we haven't seen anything like this. So it's I'm interested to see what the follow-up is going to be on this, because up to this point, we were assuming that if we were going to see a COVID outbreak in a school, we would have seen it already, right? Because we were having school back in January, February, March, before anything was closing down, and we weren't seeing any outbreaks in any schools. And now it turns out it was entirely possible that we were having outbreaks and we just weren't catching them because we weren't testing for it. And it just looked like a pretty nasty flu season. And there were no deaths. There were, as near as I can tell, there were no major hospitalizations. So it's very interesting. And for some reason, I don't understand why the Fresno public health officials weren't jumping on this and wanting to learn more. Instead, they just wanted to keep fighting with the school. So I don't know what the follow-up is going to be with this, because this would be a fascinating case to actually study for implications for the rest of our schools. Because now we're wondering, all right, is it possible to have an outbreak in the school? And what does it really mean if you have an outbreak in the school? Because if no one from this entire community got seriously ill or was died as a result, what implications does that have for other schools? So this will be very interesting. But this is, some of the challenge of population surveys. What's the sensitivity, what's the specificity that you need, and what do the results actually mean in terms of your population? Public health screening is another interesting topic, and this has got a lot of back and forth right now. Right now, the push from the FDA is maximum sensitivity, right? Which makes sense for a screening test. You want to identify all your positive results. So normally for a screening test, you want to maximize sensitivity, right? We saw that earlier. And so they have their detection goal is you want to actually diagnose your patient before you get into that infectious window, right? So we're assuming that someone starts becoming infectious, someone starts becoming contagious. We don't know how long they stay contagious for, but they start becoming contagious maybe a day or two before they develop symptoms, is what we think. And then, of course, some people never develop symptoms at all, and then that throws off all of your assumptions too, right? So your goal is to detect them right up here before they have a chance to infect anyone else, or maybe like a day or two after. So you're able to cut off most of this infectious window. So you want a high sensitivity test, has a huge it's a huge detection window, right? It can detect before someone is actually infectious, and it keeps detecting positive results for the PCR, for the molecular testing, even after they're no longer infectious, right? They might still have traces of virus in them, but at that point, the virus is so dead and gummed up with antibodies and stuff that it can't even infect a petri dish, let alone another person, yeah? So maybe they've got a window of about 7 days where they're symptomatic, maybe 7 days, maybe 10 days, who's really sure about when they're contagious? Now here's the thing, high sensitivity tests, the high sensitivity PCRs, they're expensive. You can't do them every day. They're annoying to collect specimens from every day. So say you're only testing people, once every 2 weeks. And there's really only a 2 to 3 day window right here where the test result will be positive before the person actually becomes contagious. I mean, this is all speculation. It's very difficult for us to actually test things. These are some rough ballparks of where some of your estimates might lie. If you're testing everyone once every 2 weeks, you only have a 3 out of 14 chance of actually hitting that desired window right here. Right? You see that? We've only got a 2 to 3 day window. If we're testing someone once every 14 days, you only have a 3 out of 14 chance of actually hitting in that window. And really an only 8 out of 14 chance of getting a positive result sometime before they're halfway through their period of contagious, right? So if we're testing everyone only once every 2 weeks, there's not going to be necessarily a huge public health benefit. You're just not catching enough people before they've had the chance to spread the disease to more people. Especially if most of the disease transmission happens right here in this brief window before they develop symptoms, right? Then you are missing this window most of the time. So here's what's being proposed instead. What if you went with something low sensitivity, but high frequency? What's being proposed now is, what if you get your cheap dollar test? We have the technology to do that. If you're willing to sacrifice sensitivity, you can get a cheap little $1 to make, paper strip that does, instead of PCR testing, just antigen testing for the protein in the virus. It's got lower sensitivity. Some of them maybe as low as like 50%. So it's not going to detect it as early. It's only going to detect it during this window between maybe right around when they start becoming contagious, and maybe stops right around when they are no longer contagious. But what if you're able to do it every day or every other day, once every 2 days? What's the chance, if you have a 1 day, because you have less sensitivity, you only have a 1 day window here between when the test is going to test positive and when the person is infectious. What's your chance, and you're testing someone every 2 days, what's their chance of hitting the window? About a 50% chance, right? If you've got a 1 day window and you're testing people of hitting this mark right here, and you're testing someone every other day, you got a 50-50 shot of actually getting a positive result before they've had a chance to infect anyone. And virtually 100% chance of getting a positive result before they've gone significantly through their window of contagious time. So up to this point, the FDA has been all sensitivity, sensitivity, sensitivity. Hopefully now with some of this technology being developed and proposed, some people are going to be opening up to the idea of, what if we sacrifice sensitivity to get something like this, where we're not going to diagnose it as early, but because we're able to test, because you can test everyone every day with a $1 test, right? For a fraction of the cost of all these stimulus packages, like trillions of dollars of stimulus package that the federal government did. For a fraction of that cost, you could get everyone a $1 test every day for the entire year. And if you get everyone diagnosed in this window before they have a chance to infect everyone else, right? So it's not always clear whether or not you want sensitivity, specificity, or you're willing to sacrifice those things to gain something else, right? All of this is going to be a trade-off in testing. And this is something that your hospital is going to want to think about too in your testing criteria. For your test, are you really valuing sensitivity? Are you really valuing specificity? Or would you rather have the cheapest test possible to test the widest range of your patient population possible, right? These are all going to be trade-offs that you have to have serious discussions with your quality assurance team and your management team to figure out what's the goals of our lab, what's the goals of our hospital. And that is it for sensitivity, specificity, and predictive values.